Thank you, sir. Good morning to you. And as a heart failure specialist of all the introduction part, I'm the current president of the Heart Failure Association of India. And our aim is to reduce heart failure mortality by 10% in 10 years. And my last slide, I would try to tell you how we are going about with it. And what we have found is that heart failure in India, mostly it is not treated by the cardiologist, it is treated by the physicians, diabetologists, endocrinologists. So, all the more reason for this talk. So, this person must be familiar to all of you. Who is this? This is Thanos. And Thanos, one of the famous quote is that, I am inevitable. So, why does Thanos figure in when we talk about heart failure? Because heart failure becomes inevitable with non-communicable diseases. There's been a saying that all roads lead to Rome. Similarly, all the NCDs, and especially look at the numbers from India, 101 million, 136 million, 315 million, abdominal obesity, 351 million. So, and CKD, 17.2% prevalence. So, we are a bhandar of comorbidities, and all these things lead to heart failure. So that is why, like Thanos said, I am inevitable. I say heart failure is almost inevitable in India for us, our patients, our parents, our children, everybody in the community. And it is our responsibility to tackle this menace. So 10 key statements about heart failure. 1, heart failure destroys life. 2, heart failure is common. 3, heart failure is becoming more prevalent. Heart failure afflicts the elderly disproportionately, but India, as usual, it is 1 to 2 decades earlier. Poor recognition leads to preventable premature deaths. Living with heart failure is exhausting. Heart failure is very costly. One hospitalization, directly or indirectly, will cost more than 1 lakh rupees easily. Heart failure care can be improved, no doubt about it, because the guideline-directed medical therapy in India is extremely poor. Heart failure is preventable, that's where you come in, and coordinated action is needed. So 8, 9, and 10 are the key things for everybody in this audience. And this was mentioned before, but again, putting it in perspective, lifetime risk of heart failure is 1 in 4 people. So 1/4 of us will get heart failure, and if you get heart failure, you will die within 5 years. The 5-year mortality Trivandrum Heart Failure Registry is, HFrEF is 65%, HFpEF is 45%, and 10 years mortality is 83%. So it is as bad as that. So this is not only important for our patients, but to ourselves. So let me share 2 cases. The first case is a 67-year-old male, diabetic, hypertensive, creatinine 1.3, urine albumin 2 plus BMI 34, BP 142/87, HbA1c 7.3. Nothing like, if this patient comes to your clinic, this kind of patient must have come to your clinic many a times in the last few days or months. What would you say? Oh, you're fine, you're doing well. 152, little high, urine albumin, you can control it better. Creatinine, we don't give too much of a thought to it, even though is in CKD stage 3. And is on telmisartan, amlodipine. Telmisartan is the commonest antihypertensive in India. Amlodipine is the second commonest. Then beta blockers, atorvastatin, metformin, sulfonylureas. And the complaint is mild dyspnea on exertion, some swelling of the ankles. And it has been attributed to obesity and amlodipine. So what would you have done in this patient? I'm not asking for a show of hands. But generally, we say nothing to worry, to reduce weight. Second action may be stop amlodipine. Third action may be NT-proBNP. Fourth may be echo. Fifth may be angio, because angio is very, very commonly done in our country. So what happened to this patient? Reassured. Patient did not improve. Went to a cardiologist, did the angiogram, insignificant CAD, said it is psychiatric. Then patient did not come for follow-up. Everyone thought he was fine, but it was later it came to the notice that patient had a sudden cardiac death. And 67, 68 is not a most likely was having HFpEF, which was not recognized. And sudden cardiac death is common in patients with HFpEF. Second is a patient, you can see the classical patient, younger patient, inferior MI, PTC had done, EF was 38%, BMI was okay, and was on GDMT, sacubitril/valsartan, beta blocker, MRI, and SGL2 inhibitors. He comes for review. His numbers have improved. EF is 43%. He says he walks 2 kilometers. NT-proBNP has come down. But there is a caveat there. When the doctor was little obsessed, he kept on asking, and actually it was not the doctor, it's the nurse who kept on asking. And he said, I can do all my daily chores without difficulty, but nowadays I'm taking more time to cover my routine 2 kilometers. So, but the patient had a request. I want to reduce my medications. What would you do? Our numbers are better, but he says that this kind of patients, again, you think back, you'll be seeing very common. Is the patient stable? And it is not so. So, whom to screen for heart failure? Patient with symptoms suggestive of heart failure. That includes breathlessness, fatigue, like, of course, pedal edema, abdominal swelling, etc., etc. And patients at high risk of heart failure. That is where diabetes comes in. It's a huge big chunk would be diabetics in our country. Diabetics and hypertensives. And others are related to less. Valve disease is becoming lesser and lesser. CKD is going higher and higher. And as was mentioned, this paper said that but 46% of the patients with type 2 diabetes have LV diastolic dysfunction. LV diastolic dysfunction automatically doesn't mean that they have got HFpEF or heart failure with preserved ejection fraction, but that's the pointer in that direction. Now the question is why? Because if you've not read this book, you should read this book, Emperor of All Maladies. It's about cancer. And we also, if you get cancer, if somebody gets cancer, we will be panicking. We'll do everything possible in side effects no matter, the cost no matter, proton therapy, yes, we'll do everything. But when you compare heart failure, people just do not bother. Even we do not bother, patients do not bother. But look here. The 5-year survival, the 5-year death rates of leukemia is 43%. Heart failure is 48%. India it's 65%. And non-Hodgkin's lymphoma is 31%. So, ladies and gentlemen, heart failure is more mortal than most cancers, maybe exception may be lung cancer. So, if you diagnose cancer late, one of your patients, they have come routinely coming to you, you have been checking general checkup, everything, and you miss the cancer, there will be outrage. You will feel bad. But neither the patient nor the doctor feels outrage or anything if you diagnose heart failure late. And diagnosing heart failure late is like increasing the mortality. So that should be the theme, that's the thing to ponder about. Now coming to universal definition, as Heart Failure Association of India was also part of this. And stage A is mainly diabetic patients with risk factors. Stage B, no current or prior signs or symptoms, that's important. And if they have got any structural or functional cardiac abnormality, which includes NT-proBNP or BNP or HS-tropi. And there is a position paper by ADA and AHA, and that said that diabetics should have yearly NT-proBNP and high-sensitivity troponin. How many of our diabetics forget about 1 year, maybe once in 3 years? Echo maybe once in 2 years, but these things are not done. Stage C, so stage A and B is purely your purview, and that is a huge number of population. Stage C, current or prior signs and symptoms, and stage C is treated by both, but again, majority of the patients, what we found in India, are treated by diabetologists, internal medicine, and the general practitioners. And the cardiologists are more coronary centric, and that is where the gaps are there. And once you reach advanced heart failure in our country, the game is already lost. Almost like the cricket match going on now in Manchester. So, what are the guideline recommendations? We heard about our needs for patients with heart failure with reduced ejection fraction. These are all class 1 indication, 4 drugs, class 1, no doubt. But again, how much are we giving? India, maybe less than 40% may be getting all 4 drugs. And there's a huge selection bias in that data. And Steph Green's paper it was 15% in US, 4 drugs, 45%, 3 drugs, and that was published last year. So, like even Americans are not doing that great. When you come to mildly reduced ejection fraction, these are all class 2B, SGL2 inhibitors are class 2A, maybe it's class 1 now, and HFpEF, we have SGL2 inhibitors. And why do you give that? Because it reduces death and heart failure hospitalization. And SGLT2 also reduces worsening of CKD. So summarizing the heart failure treatment pathway, initiate first-line quadruple therapy within 4 to 6 weeks. Easier said than done, because in all over the world it is not done, but it can be done. Where there's a will, there's a way. And start with small doses and titrate upwards. I start all 4 drugs at the smallest dose. And what we have found in our own analysis of our own data is that more than like 90% are eligible for all 4 drugs. Because creatine 1.5 is not a contraindication for MRA or SGLT2 or ARNI. BP of 105 is not a contraindication, but they do not get. But actual number of people getting maybe between 10 to 20%. Then add on for consolidation therapies, hydrolysin nitrates, Bradin, Verasigot, treatment of comorbidities and etiology, and monitor and for response and adjust accordingly. And if the patient is responsive, optimize, continue to optimize. And I would like to bring in the term heart failure in remission. We use the name remission usually for cancers. We don't even say cure, we say cancer in remission. Similarly, if you have heart failure, even if you are going to Shabrimala or doing a Badri Kedar, you are still in heart failure in remission. And you should look for persistent heart failure, and also should look for worsening heart failure. So the relatively new kid in the block is not exactly new, but is Verasigot. So like it has been there, approved in our country, not very costly, but I don't think very few people, members in this audience would have given on their own, but it can be given. And I would compare Verasigot with DPP4 because side effect profile is almost nil side effect, very practically less side effect, very easy to give, very easy to uptitrate. So only thing, familiarity and the perception that it was a purely cardiologist arena. So it restores the nitric oxide soluble guanide cyclase GMB pathway. It has got multiple benefits, including reducing the myocardial stiffening, because you heard about stiffened myocardium in the previous talk, reduce hypertrophy, reduce remodeling, reduce fibrosis, and improves renal blood flow, improves endothelial function. And this is the key. Even if you give all 4 drugs, which we are not giving, there is a huge residual risk. You can see the risk increases, and with about less than 2.5 years, about residual risk of what is the risk of heart failure, of death and hospitalization, is more than 25%. 25% is 1 out of 4. And so we have to do better. So there is no really stable heart failure. That's a myth. And because the disease continues to progress. So again, the Japanese guidelines were mentioned. So I will just mention about the definition of worsening. This I like because this is more inclusive and most relevant to you and to me also. So worsening signs and symptoms despite stable and optimal therapy, we have to give stable therapy. Then the significant deterioration of objective findings regardless of symptom changes, including asymptomatic reduction in LV ejection fraction, cardiac enlargement, or NT-proBNP levels. So here, if you remember the first patient, the patients had symptoms, but not evaluated for heart failure. The second patient, the numbers were slightly better, but in spite of good therapy, he came and said, now I cannot walk 2 kilometers as before. And I can do all the things. And that also, ladies and gentlemen, is worsening heart failure. And if you have worsening heart failure, it is worse than having an MI. If you get hospitalized in Apollo now, in-hospital mortality is about 10%, whereas if you get hospitalized in Apollo for acute MI, in-hospital mortality is 3%. So if you get, but when they get admitted with acute decompensated heart failure, they'll say, doctor, is it MI? They say, no, thank God. But for me, it is the other way around because it's 3 times mortality in our own hospital. So outcomes of worsening heart failure, within 30 days, 22% are re-hospitalized, 90 days, 40% are re-hospitalized, within 1 year, around 6-7% are re-hospitalized. So coming to study, this Victoria, we are stressing upon worsening heart failure and Veressigoat. So what they defined is ejection fraction cutoff less than 45, recent heart failure decompensation or IV diuretic use or heart failure hospitalization, along with elevated natriuretic peptide. And stability, they said the blood pressure should be more than 100 and should be off IV treatment for 24 hours. And you can see here the benefits. And I love absolute risk reduction. And I'm not very enthused by even relative risk reduction or even p-values. But if the absolute risk reduction is strong, I would call it a very strong study. So just look at here, absolute risk reduction of 4.2. That's quite good. And compared to other heart failure trials, Victoria stands equal, shoulder to shoulder. So it is not a secondary drug. To me, it can be a primary drug. We are waiting for the Victor results. And NT-proBNP reduction, it is comparable to DAPA or EMPA or even omecamtiv mecarbil. It's not FDA approved, not available in our country. So what is the biggest threats? Because we just do not prescribe medicines, and if we do not prescribe medicines, patients suffer. So the problems are blood pressure is too low, worsening renal function, creatinine is 1.3 like my first patient, potassium is 5.1. So these are the 3B, and when we analyze our own data, even though 90% were eligible, only 10% got all 4. The reason was, 12% actually. Reason was that people thought that the BP was too low, the creatinine was slightly high, and hyperkalemia was not that much, but these were the reasons for not giving. And Veressigoat has got practically very little effect, and people lower blood pressure, it actually improved the blood pressure. It was very, very well tolerated, and that is the important thing. And 90% achieved the target dose of 10 milligram. So you have a drug which works with very less side effects and very well tolerated. What prevents us from giving that? That is inertia. Secondly, the people will ask, where is the trial for the stable patients which we see? Because the Japanese guidelines have not been fully incorporated in Indian guidelines or American guidelines. But clinical worsening, that my second patient had clinical worsening. So I would put that as worsening heart failure. So Victor will be read out very soon, in a couple of months. And Victor encompasses everything. With best therapy, all 4, adding Veressigoat, would it benefit? And when the Victor, if it's a positive, then if you do not give, you are doing harm to the patient. So time is prognosis. If you delay the treatment, patient dies. Can we predict worsening heart failure? Yes. The symptoms worsen or NT-proBNP increases. We can predict heart failure. For that, we have to do BNP or NT-proBNP. And the cost is not too high. The point of care devices are available for 600 rupees. So I don't think we should say cost as a reason. And again, the Steph Green again, he said, okay, why do you wait till the patient worsens? By the time when the patient would die, why don't you give upfront all 5? That is a good thought process. So my thought process on patients on starting Veressigoat or in patients with worsening heart failure or even patients with quote-unquote stable heart failure or heart failure in remission are 1, contraindication or intolerance, perceived or otherwise, to one or more of the 4 pillars. Second is in combination upfront with 4 pillars. That we'll know after Victor, but many people follow that. After optimization of 4 pillars within 6 months, as a 5th pillar, but seeing that, okay, patient needs further improvement. But one word of caution is that do not use Veressigoat as a last resort after multiple heart failure hospitalization. When you do things as a last resort, it includes CRT or even that includes transplant. There's a saying about transplant, people who come walking into the hospital for transplant go back walking. Patient who comes in a stretcher either go up or go back on the stretcher. So this is how we put, because most important thing is implementation. However much education we do, however much CMAs we participate, however much talks we give, unless it is implemented, it does not work. And how can it work? So this is the structure of a heart failure clinic. So the base is cardiorenal metabolic or CKM or whatever you call it. And this is where stage A and B heart failure, where it's totally run by you, it's your responsibility. And stage C heart failure, what we call as heart function optimization evaluation clinic or HOPE clinic, is where both of us are part, cardiologists as well as endocrinologists, general physicians, diabetologists. Advanced heart failure is a territory of the advanced heart failure physicians. So this is what I conclude by this slide. So from education to implementation is the thing, and this is our moonshot. What is moonshot? A plan or aim to do something that seems almost impossible. So Heart Failure Association of India is initiating about 1,000 heart failure clinics across the country. It is not allocated only for cardiologists. Anybody who sees or interested in heart failure, any one of you can be part of it. And we train them, train the nurses, and nurse-led as an implementation program. And ladies and gentlemen, my last statement is that we hope to reduce heart failure mortality by at least 10% in 10 years. Thank you very much for patient hearing.